So welcome everyone to this webinar of Downtime Preparedness in Healthcare, Planning for the Inevitable. This webinar is presented by Region 1 Disaster Health Response System, or RDHRS, in collaboration with the Regional Emerging Special Pathogens Treatment Center, RESPECT. Both programs are funded by the Administration for Strategic Preparedness and Response, ASPR, within the Department of Health and Human Services. Some disclosures for today's webinar. The content provided in this webinar is presented by the individual speakers only and does not represent or reflect the official policy or position of any portion of the United States government. The content is not meant to be a substitute for medical professional advice, diagnosis, or treatment. The information herein should be adapted to each specific patient based on the treating medical profession's independent professional judgment and consideration of the patient's needs. The resources available at the location from where the medical professional services are being provided. And any other unique circumstances, this information should not be used to replace, substitute for, or overrule a qualified medical professional's judgment. And the speakers have no affiliation or financial interest relationships to disclose. I am Haley Manning. I'll be your moderator today. I'm a senior program manager in the Department of Emergency Preparedness and Continuity at Mass General Brigham, and I have the pleasure to introduce our speakers. Our first speaker today is Roger Osborne. Roger serves as Vice President of Enterprise Resilience at Penn Medicine, where he has led multidisciplinary teams for nearly a decade. With more than 30 years of experience, he has built and matured safety, security, emergency management, and continuity programs, and holds certifications as CHSP and CHPCP. Our next speaker is Jen Hendrickson. Jen Hendrickson is the Senior Director of Emergency Preparedness and Continuity at Mass General Brigham. She brings nearly 2 decades of experience in emergency management and continuity planning across healthcare and other critical infrastructure sectors. Jen has led strategic initiatives to improve downtime readiness and ensure operational resilience for essential digital applications. And our last speaker today is Mike Kibitza. Mike Kibitza serves as Corporate Business Continuity Manager at Penn Medicine, where he has spent over 3 years building and advancing the health system's business continuity program. With 8 years of healthcare experience, he focuses on governance, downtime procedures, and BIA BCP development to enhance resiliency and recovery during disruptive events. Thank you all for being here today. These are our learning objectives. We won't go over them today, but these are the learning objectives for the webinar. And I'll turn it over to our presenters.
Thank you so much, Haley. And thank you everyone for joining us today. As Haley indicated, our presentation is Downtime Preparedness in Healthcare, Planning for the Inevitable. Throughout today, we'll briefly cover our learning objectives, and then our hope is that we can really talk about some of our high-level initiatives we've taken to make our healthcare systems between Penn Medicine and Mass General Brigham more resilient, but also dig into some case studies that provided some very good learnings and the basis of a lot of the programs we've developed. So as Haley already did our introductions, thank you, Haley. So we'll pivot to learning objectives, downtime and context, so understanding the threat that we face today. Then we'll start with a case study around a cyber attack, specifically at a healthcare system in 2016, and Roger will walk us through that. We'll talk about downtime readiness holistically, and then talk about incident response and the criticality of communication. And we'll close with a case study related to a technical failure with CrowdStrike, which many of us experienced a little over a year ago. So these are our learning objectives for today, one of which is to integrate downtime readiness into all hazards or emergency operations, continuity planning, and response structures across healthcare organizations. To develop a multidisciplinary downtime readiness program with an associated governance structure to promote coordinated and unified effort, really enhancing those relationships ahead of time to ensure that during incident response and recovery, you're moving effectively and efficiently. To identify training and exercise opportunities for downtime procedures and response that integrate with existing processes and reduce the burden on our staff, given all that they face today. The fourth one is to document and map known clinical care impacts and dependencies, and to develop a process by which you can really query those quickly in the event of a disruption. And then finally, we want to talk about and really help all to understand the criticality of communication and being able to both understand the situation on the ground and have bi-directional communication. So we'll talk about a framework that can withstand degradation. So understanding the threat. So we'll go through some of these intro slides because I assume many of you who have joined us today are very well aware of the threat we face today in healthcare, and specifically our reliance on technical systems across healthcare organizations. There are primarily three different types of downtime events. So we have planned downtimes. Those are our ongoing scheduled downtimes. They're often done in the middle of the night. So the night shift becomes very well versed in how to work on downtime. We have our unplanned downtimes that are unintentional. So these could be from a utility failure or a number of different technical scenarios, one of which we'll talk about a little bit later with CrowdStrike. That was a technical failure from a vendor that caused an unintentional downtime. And then finally, we have our unplanned downtimes that are intentional and come from bad actors who are seeking to do some type of harm, often from a ransomware perspective. And so these are just some of the different scenarios that we face. The one that's not specifically on here, but is an underlying theme of many of these, is also the impact from vendors. We all rely on a number of different vendors for the services we provide. And what we've seen in recent years is that is another way that we are vulnerable. So many of those vendors, if they are impacted by some type of cyber event or a downtime disruption, that then has cascading impacts into our operations. So Change Healthcare is just one of those. There are many that we have seen over the years. And so that is also something we'll talk a little bit more about in making sure that you understand some of the vulnerabilities surrounding your critical vendors. So these are the various types of cyber attacks that we see across our industry, but also others. So there's phishing, and that's one of the most often done. I think we probably all are familiar with the phishing initiatives across our organizations to help us spot when those fake emails come in, and so that we can report them and keep our organization safe. There are denial of service, and there are a number of different ways this distributed denial of service attack can occur. Really flooding the network, an application, or another manner to disable traffic and really slow things down to the point of being down. Then there is finally malware. And this is the one I think we hear a lot about. This is the one where healthcare is targeted frequently, and we'll see this in the coming slides. But this is malicious software that's installed through phishing or, even physically. There are stories of USB devices being dropped in parking lots and then put into a device. And that is how the ransomware or other types of malware are put on the device. And then finally, there's spoofing or modifying or taking control of medical devices. So these are four common types of cyber attack types, and that would fall into that intentional bucket. So the risk of unplanned downtimes is a growing risk to healthcare. So the frequency of these attacks, as you can see here on this graph, and this is really only through 2021, but they continue to go up in terms of the frequency. So nearly 1 in 4 cyber attacks targets the healthcare industry. And we'll talk a little bit more about that, but it's in part due to money. It's in part due to our high reliance on technology. There are a number of different factors on why this occurs. Cyber attacks have exposed the personal health information of over 40 million patients. And one of the biggest things that always catches my eye as someone who's really looking from a continuity and emergency preparedness perspective is that the average downtime is around 4 weeks for these ransomware attacks. So that's 4 weeks on our downtime and paper processes. And we all know how just a few hours can feel on downtime and the impact that can have to clinical systems. So that's really where we'll spend quite a bit of time today. So this image really talks about what is disrupted. So the electronic health records, we often have to cancel scheduled care and procedures. Not in Massachusetts, but there are other areas, ambulance diversion, which there have been many studies that show that has an impact on patient care and how patient outcomes. So there are a number of different ways that these disruptions and downtimes impact our patients and our staff. They're extremely disruptive. We talked about the 4-week downtime a little bit earlier. Unintentional and intentional are extremely disruptive to patient care and our patient safety events because we rely so heavily on our technical systems to conduct patient care and to do those quality checks. They delay results reporting, both in imaging and our labs. They take down some of our key calculators for medication administration, and they really challenge throughput and capacity, which we know, and from the October webinar, is a challenge across all of our hospitals at this point in time. Finally, there have been studies that show a 20 to 35% increased risk of in-hospital mortality during some of these disruptions. They have a broad impact. So it impacts all aspects of healthcare, the increased time on diversion, our wait times, our EMS, the length of stay, all of those pieces are impacted, as well as the reputational impacts and concerns from the community. And Roger will talk a lot more about that when we get into the case study, but it's a very real factor and impacts the entirety of our community. And so with that, I'll hand it over to Roger to talk about ransomware.
Thank you, Jennifer. Good afternoon, everyone, and happy Friday. I'm excited to be here with an opportunity to learn from you through this dialogue and collaboration. And I'm also excited to build upon the presentations from Jennifer and Mike. And to do that, I'd like to take you into a real-world scenario, a ransomware event that affected me nearly 10 years ago this coming March. At that time, I was Director of Safety and Emergency Management for West Virginia University Health System, or WVU Medicine. Pretty large health system. I think they're up to about 30 hospitals today. But at that time, they were a really well-wired IT-centric organization. At that time, I think they were considered by a few agencies as one of the most wired health systems in the country. And I think that's important to understand as I go through this example. At that time, we had probably several generations of nurses who, one, had not seen a paper record in several years, or in many cases, we had nurses who had never seen a paper record. So I think that's an interesting dynamic. And if you can fast forward to today, I think that's even more magnified in most of our institutions across the country. What I'd like to do, maybe 2 or 3 takeaways today. First of all, I'd like to give you a sense of what it was like in that first few minutes, what it was like in the first 24 to 48 hours, and then kind of how we got control around the situation and got to where we had an effective resolution. Secondly, I'd like to talk about some of the lessons learned from that event and how we baked that into our emergency management and business continuity plan for the University of Pennsylvania Health System. I think you'll see a lot of that logic when Mike does his section of the presentation. Mike is really the brains behind that and bringing that to reality from some of the things I learned from the situation. And finally, I hope that through our discussion today, you'll take enough away with you that if, God forbid, this happens to you on Monday morning, you'll be able to respond a little bit better than you might have otherwise. As you can see in this first slide, we've had it up here for a few seconds for you to take a look at. Imagine it's 2 o'clock in the morning, 2:52, I think in this case, and you get a phone call and you get this message from your nursing administrative coordinator, IT malware event. And really at that time, I'm rubbing my eyes like most of you would be, trying to distinguish what this is. And after my wife slapped me in the head and told me to wake up, I'm trying to read this message and determine what an IT malware event is and that they're currently experiencing technical issues with multiple systems at our hospital. So obviously, I'm now also realizing that this message went out to about 8,000 of my closest colleagues, and they're all getting this message at the same time, which is concerning because we'd only implemented our emergency notification system about 2 weeks prior to this. So we hadn't had a lot of experience with these types of mass notifications. So obviously, my next thought was to give the nursing administrative coordinator a call and try to find out what was going on. Next slide, please. What we didn't realize at the time, and we learned afterwards, is that we were really a part of a more coordinated attack. There were 4 health systems across the country that were attacked simultaneously. I think one was in California, one was in Kentucky, and there were a couple more here in the East Coast, including West Virginia University Hospitals, where I was at. As you can see in this graphic, kind of displaying what those events were and how they were resolved overall and what the impact was, we were still calling it malware. And that was something in the beginning that IT, when they were trying to figure out what this event was, this is how they were communicating. And so it kind of stuck, even though it ended up being a ransomware event. We were being asked to pay in Bitcoin, which was interesting at that time as well. Next slide, please. So as I'm starting to talk to my nursing administrative coordinators, what they're telling me is we've got multiple systems going down at one time. And, I had to get some interpretation as to what that meant. So, the first thing they're telling me is, hey, Epic is down. All right. Right away, I know this is not a good situation for Epic to be down across the hospital. But also they're telling me that a lot of the phones weren't working, our web page was down. And as we started learning a little bit further into the event, the next few minutes, internet, email, and even our security cameras were down. So when that started happening, we really didn't know what we were experiencing at that point in time. I mean, we hadn't had a lot of practice with ransomware events in 2016. So, really, we were blind to our organization for those first few minutes. These are all the normal ways that you communicate out when something happens, and none of those things were available in the first few hours of this event. As a result of that, we went on hospital lockdown for about 4 hours, again, because we didn't know what we were experiencing. And then one of the first things that we really wanted to do is make sure that we were, as any of you would do, we wanted to make sure we weren't having problems with medical equipment, right? We want to make sure life support equipment and things like that weren't being affected by whatever this was. The big early impact, or the big lift early on, was for IT. So, once I called the NAC and got a feel for what was going on, my next call was to my administrator on call. We had a quick chat, obviously felt something was going on. We immediately set up a group of key people from IT and hospital administration, myself and the AOC, and we had our first command call at 5 o'clock. We didn't get to set up incident command for the hospital till actually 8 o'clock. This was back before we had Teams and virtual capabilities, so we actually had to meet in person back in the old days. But we were sort of fortunate in this scenario, and this is something I think to emphasize as we go through. We had just implemented our emergency notification system a couple weeks earlier and integrated it with our payroll. And it was the only way that we had to communicate back out, because I was outside of the network. I was able to get into the system through the cloud-based systems. I was able to send out emergency notification to everyone's cell phones, and then they were able to get a hold of employees and relay messages out to employees. But again, 8,000 people got that message, so everybody knew something was wrong right away. Next slide, please. One of the key things that we had to do early on is we had to establish incident command connection with our IT. They had their own command system. They were responding. They were diving in, trying to assess applications and figure out what's going on at the same time that we set up the hospital incident command system. So what we really had to do at that point in time is we were relaying how the applications that were being affected were affecting operations out in the hospital, because a lot of times IT doesn't know that. They were sort of zeroed into their silos trying to figure out what was going on, and I didn't necessarily know the impact to operations out there. So setting this up, and we ended up having a landline that we set up a 24/7 call that we kept open throughout the early hours of the event. The next thing that we started noticing that, pharmacy, lab, financial services, they were being severely impacted and couldn't operate. And again, we were getting ready to start up a busy Tuesday morning at the hospital with surgeries and everything else being planned. So we knew right away that, all these systems were being affected. Another thing that happened a little bit further into the incident was the arrival of various agencies, law enforcement, FBI. Getting them coordinated, putting them into a room, collaborating with what we didn't know at the time with them was an emergency in and of itself. So you should expect that in any of these events. And the interesting thing about this is that the ransom was fairly benign at that time. Now they've gone up exponentially. I've seen some of the demands in more recent events, but at this time, it was only $1,500 to $3,000, and they wanted to be paid in Bitcoin, which we didn't have the capability of, and something we've since baked into our plan at the University of Pennsylvania. Next slide, please. I will talk about some early two-way communications. What I wanted to do is give you a sense of some of the things we were hearing and seeing at that time. Just to give you. So you can see here at Tuesday at 8:31 in the morning, that was the first time we had to activate our command center. And again, this is going out through our emergency notification system, which we also had the capability to communicate with the managers two ways. And that became vital as we got through the emergency, that two-way communication, because we really had to have a way to assess the impact of what these applications were having on operations out there and which applications were affected. And so what we were able to do is use our emergency notification system for our department managers to report back what those impacts were. You can see here Tuesday at around 12 o'clock, this is where we started seeing financial services, Citrix, our Epic applications, the claim scrubbers were down, batch room, so anyway, you can start to see it escalating very quickly. Go ahead and go to the next bullet point, please. Tuesday, 12:40, value analysis, purchasing, SharePoint, all of those things started to be affected. Lawson, desktop, we started realizing several desktop units were being affected as well. And then around 1 o'clock that same day, inpatient pharmacy. And this is something that was interesting because one of the most difficult things we had to get back up online from this event was the pharmacy robot, which was critical in dispensing medications for inpatients throughout the hospital. So we had to immediately start converting to doing that manually, and that was a real bear to do. And it was almost 2 weeks before we had that system back up and running. But you can kind of see some of the other things here that we were dealing with at that time as well. Next slide, please. Some of the early communications at 1:06 p.m., chemistry lab, the automation line was down. We were hit by the virus. We had to completely take down the automation line, and we were projecting several delays at that point. At about 2:30, we started seeing our critical care units, desktop computers, the nursing stations were not working. So you can see very quickly barcoding, all those things, all these things were going down as we were able to get this information back from the units. And this is, again, this is the two-way communication coming back from the department managers and leaders from these areas in real time. And then Thursday at 8:54 p.m., this is when we started being able to get our hands around the situation. We were starting to get things back up and running. Epic was one of the first things that we were able to get back up and running. Fortunately, I think within that same day, we were able to get it up and running. But as you can see here, we're starting to project that we're going to see several systems extend into the following week that we're going to be affected by this. Next slide, please. So some of the key things in a part of the response and recovery effort, you see here the first one, incident command was activated. We had the IT specialists, they were the heroes in this scenario. They were going out assessing all these servers. They ended up replacing and re-imaging over 14,000 computers and servers across the organization. That's a huge and that was because we made a decision not to pay the ransom. So that, this was the impact of that. Again, the ransom was $1,500 to $3,000. So as we're getting into this, we were really starting to think about, whether or not we should have just paid the ransom to move on. But at the advice of FBI and other law enforcement officials, they were encouraging us not to do that. The other thing that we did was begin deploying new security software almost overnight to all the servers that we were rebuilding because we were worried about another attack on the backside of that. One of the big things is that we didn't have any evidence of any type of data breach in the patient information. That becomes real important to be able to communicate out to your communities, as I'll touch on here in a minute. Most of the systems were installed within 2 days, but some, again, went out to 14 days, again, with our pharmacy robot. And then we already talked about decision not to pay the ransom. Next slide, please. So some of our key lessons learned. And these were the things that we really baked into the plan that Mike's going to talk about here over the next few minutes. Probably the biggest one we had was that, our more experienced nurses, who had used paper records in the past. Again, we were 8 years into this, so it had been a while that even some of those nurses had been able to do that. But they were very quickly able to train and bring people up to speed on the fly to be able to do manual record keeping. So again, we had generations who had never seen that paper record. So I think the key piece here is you got to build super users into your program that can fulfill that function. And Mike is going to talk about that a little bit more here in a minute. The next lesson learned is being blind to the organization. Probably the most uncomfortable feeling I had was that moment that I talked to my administrator on call, and we realized we had no way to get a hold of 8,000 employees coming in that day who were getting ready to do surgeries and all these other things. We had no way to communicate. We did have some landlines between the departments, the brown phones that we called them, that we were able to use, but we had no other communications out. We didn't know what to tell people. We had no way to communicate with our patients because the normal ways we would do that did not exist at that time. So that is a very uncomfortable feeling. You want to make sure that you have redundant communication, cloud-based solutions that you can get outside of the network and be able to get those messages out to your employees. And you want to have multiple ways to get to the internet because it could be other situations that could affect this as well. And then finally, I think early and expedient communication to all the staff. You really want to have prescriptive messages about what you want to tell them to do or not to do. In this case, telling employees, and again, there are all of these scenarios are nuanced, but in this case, being able to tell our employees not to log on to the network was huge because every time somebody logged on, those were computers that we had to go out and replace and repair. So it greatly minimizes and mitigates damage at that point in time. And then finally, kind of the last big thing here is make sure you have a plan to communicate with the community. When it starts getting on the local news and it starts advertising out to the community what's going on in the hospital, you can guarantee that their loved ones are going to be calling, wanting to know whether or not life support equipment and things like that are working. So you should really be anticipating that, have pre-canned messages and things that you can communicate out, and that relationship built with your public relations and communications team to do that. So with that, I've enjoyed the opportunity to present some of this. I'm happy to answer questions as we go through in the chat, and I will turn it over to Mike or Jennifer. I'm sorry.
That's okay. I'll do a quick overview. Thank you so much, Roger, for that. So with all of that in mind, one of the things we want to touch on from both the Penn Medicine perspective and the Mass General Brigham perspective is how do we get ahead of this? How are we ready for when the inevitable happens? So we'll quickly go through both of our downtime governance structures. And one of the things we found through the partnership between our two organizations is that we have a lot in common in how we've approached this. So you'll see that as we go through. So as we talked about during the learning objectives, given the risk of cyber events and other downtime incidents, it's really critical that we integrate downtime and cyber preparedness into all hazards planning and approach. Establishing those relationships with information security and the digital teams well in advance so that when you go into response, you are coordinated, you're collaborating, and you know how to work effectively and efficiently. And this translates to making sure that you're training together, you're exercising together on different levels, and you really understand those relationships and how they work. Emergency preparedness through both of our groups is key to the facilitation of this because of the ability to pull in and collaborate with multidisciplinary groups and to pull in the appropriate stakeholders to really get that diversity of thought and the appropriate actions going across these complex organizations. So this is just one systems approach to the Mass General Brigham system. I think you'll see something similar in just a second from our Penn colleagues. But we take a three-tiered approach across our enterprise. Each of our entities has a downtime committee. You can see the membership here. I won't read that to you. But it's really supported and tied into the COO, which I think is really important. It has that executive level leadership. We then have an enterprise level committee, and each of the entity co-chairs also serve on the enterprise committee. And that's where we really bring things together, and we have working groups across all of our various entities that develop and define the work that we're doing. And finally, we have an executive level committee. And this has been absolutely critical and such a strong support, because as we look to implement things that are coming out of proposals from the enterprise-based committee or working groups, the executive committee is able to really give that a stamp of approval and provide feedback and really ensure that there's the correct level of buy-in and support behind these initiatives, particularly if they disrupt operations. Obviously, training and exercise can, or if they require funding. This is a peek at the working groups we host at Mass General Brigham at the enterprise level. So you'll see some of our key priorities here: planning, forms and tools, and training and exercise. We also have some defined working groups related to reconciliation, which I think we all know is one of the most challenging parts of downtime from when you come back up, but particularly if you're looking at an extended downtime and how you do annual entry. And communications, which we'll touch on a bit later in this presentation. But these are some of the common themes. These are also things we've seen out of after action reports following different downtime events. And there's been tremendous work across the enterprise to bring all of this work together. And the final thing I'll say is, one of the questions we get asked a lot is, how do you plan for downtime? You can't possibly plan for every scenario. There are thousands of applications just in our health system alone. So how do you plan for each one of those? And one of the things that we have tied specifically into ours, and I think Mike can speak a little bit about for Penn, is that we've taken a capabilities-based approach, and really we're weaving it in with continuity. We're looking at this in terms of how do we keep those essential functions going? How do we use this information to make sure anything that is critical to patient care continues to operate, so that we continue those key functions for our patients and our community? And we really look at this from a functions based, and then we look at the dependencies. So what are, if we have a specific type of radiology scan, what does that rely on? What digital system specifically does that rely on? Supplies, staff, and others. So that when we get into any type of disruption, we're able to query that, and we're able to see specifically what types of care could be impacted. And I'll hand it over to Mike to say a little more about Penn Medicine.
Thanks, Jen, and hi everyone. Excited to be here. Thanks for your time today. So this here on the slide is our kind of a glimpse at our committee structure at Penn Medicine. As Jen mentioned, ours are, as we went through, ours are very similar. We don't have the exact details broken down here, but to give you a glimpse at the kind of 4 levels we have, and then connection to the board, and how that all integrates. So I won't get into detail around the committee structure, but the one thing I want to highlight here, and it goes into that capabilities-based approach Jen mentioned, is the functional leadership group that's kind of dotted line on the side there. That actually has been something we've been working on for the last year, or maybe a year and a half now, that has come to fruition. And really it came out of some of our after actions and debriefs over the last fall of 24. We had CrowdStrike, we had 2 other pretty major downtime events in the fall last year. And while we did good overall, one of the things that was found was that we need to have a better process for making decisions across the system. And an example of that is with peri-op and surgery. One of the situations where, we had a downtime and it was impacting a lot of areas, a lot of systems. Some hospitals, surgery wanted to continue, some hospitals it didn't. So it caused a little bit of that back and forth, and, no real clear direction and decision was be able to make, at least in a quick manner. So as you can imagine, if that were the case and we continue at one, not the other, there could be some negative outcomes potentially, and, potentially some lawful consequences there as well. So with that, we created this process with the idea that we have our functional areas, and really we're thinking, the different areas of the hospital. So like lab, pharmacy, supply chain, peri-op, many others that we coordinated. We worked with leadership to identify leaders for each of those areas who can essentially be that point person and the person that everything runs through when there is an incident, to work across the system for their functional area, to be able to make decisions, communication, work through communications up and down. So that way we have a clear process throughout the system for an incident. So I wanted to mention that because it was a large effort, and we are looking at that from that functional lens, as well as there's other lenses to look at it too. But this has been a key process that we've worked on that could help many others. At this point, we've met in person with this group, done tabletops. We now have quarterly meetings and do drills and many other things, and they've really been a key process of or part of our process. Next slide. And so speaking of workshops, exercises, training is another key area and very important area of incident downtime planning. A couple topics here, a couple areas of training and exercises that are important. We have some buckets here of options and some things we've done, and I'm sure many of you have done similar things. The first one is cyber leadership tabletop exercises. So this is specific to cyber type events, but one thing we realized that we needed to shore up about a year or two ago was that we needed to have more drilling and exercise with our senior leadership, and also make sure we had vendors on retainer for cyber incidents to help us respond to those events as well. So for leadership, obviously it's important for staff and managers and all levels, but it's just as important or sometimes more important that our senior leadership, even our CEO and our board, understand their role and responsibility when there's an event like this. It's all hands on deck. Secondly, to the vendor part I mentioned, that's something we realized we didn't have. We had some, but not really all of it in place, where things like ransomware negotiators, crisis communications, system recovery on the IS side, having those vendors on retainer and essentially built into your process and your program is very important. They can have a huge impact when there's an event, and not only having them ready to go, but also part of the exercises. That's something we've also done over the last year. We've had 2 exercises where we included them, and it's been a good collaboration. So they understand what our process is, we understand what they expect, and we have that kind of face-to-face and understanding of what to do when something happens. Secondly is workshops in the middle there. At Penn, that's something we've used and really used at the beginning of our program. We first started maybe 3 or 4 years ago as a key opportunity to identify many strengths, but also just as many or maybe more weaknesses or gaps in downtime and cyber planning. At this point, we've done a lot of them. I think I want to say we're at 7 workshops. Each one, usually there's 100 or so people. Pretty large efforts, and lots to pull off, but it's definitely worth the effort. These have been critical in our planning and goal setting. And initially, we identified, as I mentioned, a lot of gaps that were there's a lot to identify or a lot to work through that we identified, but also it helped to set our goals. And that's been a key part of our programs too, of while there was a lot of things to work through, how do we took those things that were identified and said, all right, what's our priority? We can't do everything all at once and knock everything out, but where do we prioritize these over the next year or 2 years, and kind of made a roadmap into what we're going to accomplish. And looking back now, 3 years ago, 4 years ago, we've really, I think, done a lot of that, and it's showed benefit. And then lastly is staff training and exercises, and maybe even the most important is making sure staff know their role. They feel comfortable, they understand what to do when there's an event. There's a lot of staff. We have a lot of people in our organizations, especially I know Penn and MGB, and I know a lot of larger health systems have a lot of employees, but the more staff that can know what to do, the better. Even if it's just a little bit, they don't have to know obviously everything, but understanding key things like where's your downtime procedure, where's your downtime forms, your downtime computers, know those key processes of what to do. And then something we've done recently over the last year is drill our departments and make sure staff go through downtime drills so they understand those procedures, those processes, and it's been really beneficial. Really good feedback on that, and I think it's going to be probably an annual thing going forward. Next slide. All right, pivoting a bit to incident response here. This is something you want to make sure you have in place is a quick and effective method to activate incident response. And talking through with Jen, we have similar processes and we use systems to do that. You can see on the screen. So you want to make sure you can do that in a quick manner and fashion, kind of like Roger mentioned earlier with sending notifications and having templates. Another key component of incident response is, I'm sure many have heard before, is HICS, Hospital Incident Command System. This is important to make sure you have a clear process and decision making. HICS will vary, obviously, depending on the event and depending on the system and the approach. But one key aspect is always having an incident commander. You've got to have someone in charge and making final decisions and being that point person. Some additional components and considerations of incident response, and Roger touched on a few of these, but having a virtual command center option has been very critical, especially post-COVID era. I'm sure many have done that, but having templates built so that can be done and activated quickly. Making decisions and communication pathways, understanding how to communicate, make decisions in an effective manner. And then another key topic is variability in downtime procedures. Some departments may need to go to downtime procedures and downtime forms earlier than others for patient safety reasons, but understanding if that is, what that process is, if it's accepted by the facility and department as a whole is critical. And then crisis vendors I talked about, and third-party vendors, Jen mentioned earlier, but this is something that I know a lot are focused on. It is a risk, obviously, and it's something that's out there is something to focus on and do risk assessments, make sure you understand your vendors, their risks, and especially they're in our environments. So we should know it's a big lift to do that, but we should make the effort to understand what potential vulnerabilities they may cause as well. All right, I think I'm handing it back to Jen.
Absolutely. Thanks so much. So one of the key items we touched on a little bit earlier is the criticality of understanding impacts and dependencies. And so what I have pictured here is one of the tools we use at Mass General Brigham. It is a very simple survey-based tool that if something is happening, it is one of the fastest ways we're able to get a pulse on what is happening where and how bad. And so this is the dashboard aspect. It tells us, is something a major impact, minor impact, is it completely not operational, and what's driving it? And so this is just one of the many ways we take a pulse on the local operations. And this is something our team uses, particularly in digital disruptions, as we try to understand how the front line's feeling and how the different mitigation measures we need to take at any given time. So this is the incident impact assessment. And in just a second, I'll talk about the continuity essential functions database and dependency mapping from our continuity experts. And this is also a critical tool as we're able to query and search and see, okay, if X application is down, that means these tier 1, which are the 0 to 8 hour functions, are impacted. And so we need to take X, Y, and Z actions, or we need to make sure they have implemented their continuity plans or downtime procedures so that we continue safe patient care as seamlessly as possible. And so this is just an example of dependency mapping. So, you're looking at radiology, those tier 1 functions or tier 2 functions. What are those digital dependencies? What are those supplies, systems? And then really, working with your digital colleagues, and it's very challenging, especially when we have thousands of applications, understanding even the physical devices that touch those applications and processes. And so that I don't think I can overstate, especially with this topic, the criticality of building those robust relationships with your digital or IT teams. And I'll hand it back to Mike to talk a little bit more about their mapping dashboard.
Thanks, Jen. And I'll go through quick. I see we're running maybe close on time through the next couple slides at least, so we can get to CrowdStrike. But this is something we've been working on over the last year or two. It's an application dependency mapping dashboard. We're now working through business impact analysis with our departments, and this will allow us to understand, if there is an application or multiple application outage, what those impacts are, who uses those applications. That's something in the past we didn't really know, besides going out and asking people and our EIOs and our facilities doing that. So it took a lot of time, and it was not really 100% accurate in a lot of cases. So this will really help speed up that response process. And this is something we're doing with other things like vendors and financial data. A lot of cool activity that we've been working towards for a while and look to have soon. And I think next is communication, everyone's favorite topic. So as we all know, communication is not easy. It's always one of the top, if not the top, action item on every debrief after action report. Is no matter how good we are, how good we think we are, it can always be better. We can always be faster. And you know, it's a tough thing to do. There's a lot to consider, and especially these situations like downtime and cyber, where there's a lot of information you're trying to process, and there's multiple teams maybe involved in trying to craft that communication. You got to get approval, those kind of things. So doing as much as you can ahead of time is really the key message to take away here. Something we've done and that's really been helpful is have a planning team that gets together. We started a year and a half, 2 years ago, got together and worked through 2 process flows of network and internet up, and the other one's network and internet down. So we understand what communication modalities we could use based on those 2 scenarios. Obviously, you can go down a little deeper, but that really hit a lot of the things for us. And then understanding who's going to do what kind of communications, having templates built and all those things. And then also just building relationships with the people that are going to be involved in those communications, so you can have a quick process for getting that information out. And then, as Roger mentioned, internal and external. These situations, especially cyber, ransomware, external, there's going to be just as much, if not more, communication that's needed to lessen the blow, I guess, if you will. So, yeah, the message is it's not easy, but planning is the key and having a good process around it. Next slide. And here is just really touching on alternate methods of communication. So, we have our primary, we have a lot of communication modalities we could use in normal times, but in non-normal times, a lot of those things are wiped out. As I mentioned, network, internet down. We realized with our planning team, I can remember the moment in the room when we kind of like crossed out everything that will be gone from the network and internet up side. And it was like an aha moment of, oh boy, we don't have too much and got to really figure this out. So, going through that process and understanding what your backups, your alternatives would be, having those out of band communications where you can at least send mass notifications to a facility or system wide or a group and have some people that can do that. It doesn't have to be everyone, but at least some capability to be able to communicate with your teams and your staff is obviously critical. Next slide. All right, CrowdStrike. We're gonna scare everyone again with another scenario. So we talked about Roger's fun he had 10 years ago. So we'll talk about the more recent one that I'm sure many of you that were involved or have some experience with, was CrowdStrike. And similar to Roger, and maybe some of you can relate to this, is I got that call at 2 a.m. Luckily we do have a process that corporate emergency management, business continuity, me, Roger, and John, our emergency manager, get notified for critical events on the IT side. And, they started getting calls. You can see on the timeline here of events, they started getting calls around 1 a.m. to the service desk from staff that computers were not working, and they were having issues getting information or getting onto the computers. So I got a call. I think I missed the first one, woke up to the second one, and I have it saved as the service desk in my phone, and I saw service desk, and I knew it was middle of the night, obviously, and so I knew it wasn't a good thing probably, but I answered, and they said, "Hey, Mike, it's whoever from the service desk, and we're hearing from staff they can't get to their computers, they can't log in, and they're seeing a blue screen of death." And that's apparently that's a common term. At the time, I had no idea what that meant, but I knew it sounded bad, and blue screen of death was a pretty rough term to use when you're half asleep. So, from there, my initial thought, I remember, first time in a long time, I remember feeling my heart sink, that bad feeling in your gut. You're like, oh, this is the thing we've been planning for the last couple of years. So anyway, we kind of get on the call. There's an IS call that was able to be activated. We could only use our phones at the time, obviously, with the computers being down. and we started our process. Luckily, about a month or two before that, we just activated and exercised we call Enterprise Incident Support Team, or EIST. It's essentially our health system command center, and implemented that. And we always have had our command centers at our hospitals, but never had a system approach that was really too structured or super structured. So did a lot of work on that, and up until about a month before that. So we were able to, it wasn't perfect, but at least activate that process and pull our teams together. And, by about 5 a.m., maybe even a little less, 4:30, we were able to have that process activated. Our IS teams were working on the issue. We also had our command centers at the hospital running. And it was around, it seemed long, but around 4:30, 5 o'clock in the morning, that was when we started to realize what was really going on. And, it was a CrowdStrike issue, it was a vendor issue, and the IS team started to get the information on what to do to get things back to normal and have that information. So from there on, you can see that was kind of where the recovery started, I guess. It was only a couple hours in, but it took a couple days, just because like the situation Roger mentioned, is you had to touch every computer and go around, and there was a process to that. So luckily, we had a lot of teams, a lot of people going around for a couple days and doing that. And it took a large effort, but really it was Friday morning till essentially Sunday night, and even into the next week a little bit. But Sunday night, we had all of our servers and most of our workstations restored, and back to normal. So with all that, the next slide I'll mention just real quick, or share real quick, is our Enterprise Incident Support Team. We'll go through this. There's a lot of detail, but this kind of outlines our flow, our process of how we activate that team, how it ties into the system and all our hospitals and services, and works through that flow of communication and activation processes. So with that, I'll turn it back to Jen.
Thank you, Mike. And so I'll just go relatively quickly so we can hopefully have a few minutes for questions. I did answer one that was posted in there, and I think Mike and Roger, there's one that's a little more applicable to some of the dependency mapping and dashboarding you showed. So this is just the high level of some of the after action themes from the Mass General Brigham CrowdStrike experience. Obviously, downtime readiness being one of the huge ones that came out of it. Because of the time we were on downtime procedures communications. We just talked extensively about that. And then how do we ensure the appropriate HICS connections and integration across the system, given the complexity of these scenarios. Some of the sub-themes within downtime are really, the forms and kits were a big one. And so forms are a challenging area for any place, because they don't specifically look exactly like Epic or another EHR. And so how do we make those as user-friendly as possible that reinforce safety, and we provide all those tools? Training and exercise was also a big one that came out of that. So Mike touched on what Penn Medicine is doing. We're doing similar things. We also have some just-in-time training and some light lift skill drills that we're rolling out. All, reflecting on the after action and the feedback we receive from CrowdStrike and other areas. I mentioned earlier, reconciliation was extremely challenging. I think this is a common theme across healthcare systems. So it's a concerted effort of ours right now to really hone in on the quality and safety focus, and then come in through with a compliance and revenue cycle eye to things. So none of these are particularly surprising, but do provide a little bit of perspective on some focus areas that we took out of that event. These are our high-level observations. Many of them reflect what we've already discussed today. Alerting and notification, having a framework that can withstand degradation is absolutely critical. Making sure your HIC structure reflects your organizational structure and you have those relationships built. I mentioned earlier results reporting. It surrounds every aspect of care we do and can really slow things down if we don't have that process completely solidified heading into these events. I won't touch much on training and exercise for reconciliation. I think we've talked quite a bit about those. The last piece I will note is resumption of service, and making sure, particularly across an integrated healthcare system, that that is done in a coordinated way. And it's very clear who is making the decision and how that timing is working, because it has patient safety impacts. So in closing, I won't belabor this one and read it to you word for word, but downtime readiness is absolutely critical to enhance resiliency, as we've walked through several different types of scenarios, both intentional and unintentional. Obviously, we have our planned downtimes as well, and we have to integrate that into all hazards preparedness and make sure that we're doing the appropriate training and exercising in advance, as well as building those critical relationships. So with that, I will hand it back to Haley to see if there are any additional questions for us.
Thank you, Jen, and a big thank you to yourself, Roger, and Mike for this great webinar. We do have one question in the chat asking to talk more about the forms and kits that you mentioned, Jen.
Absolutely. So at Mass General Brigham, and obviously Penn, folks, you can talk about this at yours, we are working towards enterprise-based forms. And so our forms and tools colleagues have done the heroic work, our co-chairs, of going from about 2,400 forms across our healthcare system to right now about 200 forms. That will grow as we continue to refine those. So those are the enterprise-based downtime forms that are really taken with that patient safety aspect in mind, and also to reinforce the processes that we use or lose with any of our EHR being down. The toolkits as a whole vary depending on the space and the where we are. If you're in the emergency department at one of our large AMCs, it might be a giant cart that pulls out to facilitate. If you're in a smaller ambulatory clinic, it could be a box under the receptionist desk. Those kits have procedures in them. They have downtime forms in them. They have just-in-time training. Some of the leaders on our downtime work have recently developed amazing job action sheets that lead your first steps. So when you're having that panic moment, when your system's down, you know exactly what to do and where your resources are. So those are some of the key items that are in our downtime kits.
Yeah, we're pretty much the same. The only other thing I'll mention is that we have, not all, but some groups have went through and done like completed downtime forms as examples. So that way, to Jen's point, you kind of have like something to go off of where you can mimic or at least have an idea of how that looks, for those specific forms. And we've done a ton of work too on standardized or having one form instead of each hospital having their own form. It took a lot of work to get actually we have like a box up top now, which you check which hospital it's for. Which that took more work than expected to get that past the finish line. But now that we have that, we can kind of essentially do standard forms across the organization, which is nice.
Great, thank you all. And we are at time, so I just want to big thank you to Jen, Roger, and Mike, and a thank you to our audience today for joining us, and hope to see you all again.
Thank you.
Thanks, everyone.
Thank you.